So, if for whatever reason you stumbled upon us or you've been following this journey of this podcast, I think we just reached over a year and a half of doing this, and it has been a journey. But one of the many highlights rather, is having Geoff Murphy and the Master Your Medics team come along, sponsor the podcast, have the faith and believe in me. I'm not going to say for whatever reason, but for whatever reason. But so a lot of good things along the way since Geoff has taken me under his wing, and I much appreciate it. But even more so, I appreciate the education and clinical insight that's provided by Master Your Medics and the courses and the education and the amazing team that runs the program and system. But today we have Geoff and his vast wisdom and knowledge and all the things related to EMS. And this is not his first time on, so I'm not going to do the whole introduce yourself because last time I called you Geoff and I will never live that down.
Oh man, I had that joke locked and loaded and you took it away from me.
I have with me not Geoff, as I've quickly learned, but I'm going to fumble that many times. I have Geoff Murphy.
Dude, I still, like, my cousin who listens to the podcast, she's not at EMS, and I'll say something about it. She's like, oh, it's Geoff. And I'm like, okay, cool. I love this for me. But, so one of the things that the Master Your Medics, if you don't follow their Instagram or Facebook page, you are missing out because they post different, like, part of the course program is these little, like, y'all attach like GoPros on y'all and run through these patient scenarios with actual, like, not HIPAA violations, obviously, but real life patient scenarios and stuff like that. And you provide an opportunity for people kind of chime in and, answer like, what do you think is going on? And why do you think this treatment is unnecessary and stuff like that? But we're going to get into one of the particular videos that I think stands out just because it's we'll get to it. But a big thing about getting through paramedic school, getting through passing registry, passing this, that, and all the great things and the great amount of pressure with learning all the things is being able to use clinical judgment and narrow down what we call a differential diagnosis, because we can't diagnose in the field, but we are provided with all the education tools and tricks up your sleeve to narrow down using your vital signs, using a good physical patient assessment, the HPI, all the things, nature of illness, mechanism of injury, et cetera, to come up with what your clinical judgment of the differential diagnosis is. What do you think is going on with the patient? Because you can use all the things you're gaining, your vital signs, your assessment, et cetera, all that stuff, and create a pathway with your protocols to figure out how do you treat your patient. And then also considering what is the long-term effects of XYZ that you're going to do that's going to affect the patient when they get to the ER, if they're admitted, blah, 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 blah. So many things. But they kind of help you steer you in the right direction, long story short. And it can be something as like a funnel. So you have how I go into calls. You have your difficulty breathing. Okay. So we start off big, and Geoff, if you want to add in, chime in, you have a difficulty breathing. It could be COPD. It could be asthma. It could be anaphylaxis. It could be pulmonary embolism. You just go in with this giant, I look at it like a cloud, just this giant, like those thinking bubbles. It's all of those things inside of your thinking bubble. Mm-hmm. And so you go in, you look at the patient, you get your history, you get what kind of medications they're on, you get your allergies because that's very important. You figure out, when did this start? What's been happening? Is it better or worse with this? And so you narrow down like a funnel, and it just gets narrow and narrow until you come up with your differential, and you're like, okay, this is what I think is going on. And you look at your protocols and you use your clinical judgment to decide, okay, just because this patient has chest pain doesn't mean that they necessarily need aspirin and nitro because I ran a 12 lead and all of the things. So it's a big understanding of what to do and / or what not to do. So Geoff, if you have like a different method or any tips and tricks to kind of add in along the way? What you got?
Yeah, I mean, I think that when it comes to a differential diagnosis, and for those of you saying that, hey, paramedics don't diagnose, you're probably right, but also probably a little bit wrong with that too, right? Like, we do have to come to conclusions in order to treat patients, and that's essentially what a diagnosis is. It's a conclusion of what's going on with the patient. Are we always right with our diagnosis? No, but I think the big thing with a differential diagnosis is that just like Alexis is saying, is that it starts off broad, and then we look for clues in our patient in order to narrow it down. And so that's the way that I look at it. And what makes you good at doing a differential diagnosis or continuing your differential diagnosis? Well, there's a few things that make you better at it. One, experience, which will come in time. The second thing, knowing and understanding pathophysiology, not just, a list of common signs and symptoms for something, and being able to kind of like identify things like that. That's not really how that works. It's just truly understanding pathophysiology is going to help you broaden first your differential diagnosis, and then your understanding of pathophysiology will help you narrow it down again, in order to kind of figure things out. And so the video that Alexis was bringing up was one that we posted. It was a female patient that was having epigastric pain, and it was the patient itself was throwing up into a bowl. And what threw everyone off, and which kind of like broadened out the differential diagnosis, is that the vomit was red. And so it's just broadened out people's idea and essentially imagination of what could possibly be wrong with this patient. And so when you're walking into that scene, so imagine yourself walking into that scene, seeing this patient saying that they have a sudden epigastric pain, and they're vomiting something red into a bowl, and they're saying that they really don't feel well. Remember, she's female, she's mid 40s, mid 50s, like in that age range. And so that's all you have at that particular point. And so this is where you start building your differential diagnosis. As soon as you get enough information to start going, okay, it could be this, 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 and this. And so in that particular case, let's kind of start at that funnel. Like, what are 5 things that it could be? What are 2 or 3 that you can think of just off the bat with someone that has those symptoms right now?
Oof. Um, don't put me on the spot
Come on,
like that.
paramedic,
No,
let's go.
yeet. Uh, I mean, I'm going very broad. Either, I mean, based on our history, we could think of esophageal varices. We could think of, hopefully not a AAA. We could think of some kind of like an OB crisis or something like that. I mean,
Okay.
there's so many things. There's so many things.
Yeah, I agree. I think that there's some of the things that you got to think about are exactly those. Esophageal varices has got to be high on that list, and make sure you rule it out, because that's a pretty critical thing to not miss. Mallory-Weiss tear, gastroenteritis, like these are all things that are possible. And I think the biggest one that we need to think about, epigastric pain, someone in mid 40s to mid 50s, female, sudden onset with vomiting. We got to be thinking myocardial infarction with that particular
Mhm.
patient as well. And so there's a lot of things that we need to be looking at here. And so that's the funnel. That's the big part of it. And just thinking of all these things that could possibly be a problem. And what I thought was interesting in the comments with this particular case, and I'm going to give you the answer in a little bit here, but what I thought was interesting in the comments is that um, people saw the red in the bowl, vomit, and immediately thought that's blood. It has to be blood. And there's no way it can't be blood. And this is a classic tunnel vision type of situation. Because if you think about, even another example of this would be the patient has chest pain, and all you're thinking about is myocardial infarction. You're not thinking about PE. You're not thinking about aortic dissection. You're not thinking about anything else that it could possibly be. But there's 5 or 6 different deadly versions of chest pain. And so that's kind of what was interesting in the comments with this, is that they saw the red blood and they immediately thought blood. Okay. Or they thought blood was in that vomit. But what else can make red vomit? Beets.
I was gonna say beets.
Yeah, beets. I mean, beets can make that. I mean, Gatorade can make that. Red wine can make red. There's a lot of different things that can make red in vomit. And so, even though that's a very interesting clue, it also can throw you off what's actually going on with this patient if you only focus on that. Okay. So that's why when you're differential diagnosis and you given this funnel, you need to be thinking not just focusing on the red blood, but also thinking, okay, epigastric pain, they're a sudden onset, all of these other things that you need to be thinking about and be like, okay, MI is up there, other types of cardiac issues are up there, gastroenteritis, Mallory's, and esophageal varices. That's all up at the top of the funnel. And then let's look at the clues that are within this. Okay. She's female with epigastric pain and in an age group where myocardial infarctions have abnormal looks to them. Okay. That's a clue to put us more on the side of a myocardial infarction. How about the fact that she was when you look at the vital signs, what is something that was there? Well, she had bradycardia, she was hypotensive, and she was also in a 3rd-degree block. Okay.
Mm-hmm.
Of your big funnel, your Mallory's tear, your esophageal varices, your gastroenteritis, and your myocardial infarction, when you have a 3rd-degree block that's bradycardic and hypotensive, as well as all the other presenting symptoms of those big, broad things that you're thinking about, what could be it, which is the one that's most likely?
Probably the MI.
Probably the MI. And that's where we need to be using our differential diagnosis, that big broad funnel, and then using the clues that come up almost immediately and be like, okay, the most likely of all my differentials is this one. And then you run with that one. Okay. And that's how you really want to be focusing with differential diagnosis. It's okay to have 10 different differential diagnoses at the beginning. And a lot of times, especially in our realm of things, we get such non-descriptive presentations and vital signs that you end up probably with 8 or 10 different differential diagnosis. And then from there, you simply pick apart your options with the clues that you're given. And in this particular case, it's okay to think that this patient could have esophageal varices. It's okay to think that it could be just a gastroenteritis. It's okay to, focus on the MI. What's important is to make sure that you look at all the other clues to rule in and rule out all of those options. I mean, from an esophageal varices situation, are they acute onset? Yes. Do they come with a lot of epigastric pain? No, they're more up high, right? Up high pain if they have any pain at all. The blood is more coughing blood and not really vomit blood. So that would be another thing to kind of rule out that maybe esophageal varices isn't here. Gastroenteritis, that's probably your more likely one with this, but doesn't fit with the bradycardia or the hypotension. Like gastroenteritis doesn't cause that. So you're really left ruling out and leaving the most likely suspect as your MI. And that's how differential diagnosis works, is that you simply stay broad and then look at your patient and kind of compile all the different hints and clues that you have in order to identify who's the most likely suspect. Okay. So that's my way of doing it. And it's always kind of served me well. It's helped me identify different pulmonary embolisms as opposed to a myocardial infarction. And so I work flights. And so a lot of the time we're picking up from emerges, like the little small emerges that don't have the ability to do a lot of diagnostic testing. And so when we go there and they're like, yeah, this patient has myocardial infarction, probably an NSTEMI is what they're thinking, because they have chest pain and they kind of fit those symptoms. And then you start to really look at their end tidal CO2. You start looking at other things that just don't line up with a myocardial infarction, even if it is an NSTEMI. And then it turns out that it's a pulmonary embolism. And that's all from, okay, this patient has chest pain with non-descriptive ECG changes. What causes that? MIs, PEs, aortic dissections, what else? Pericarditis, all these things can cause all of these non-descriptive ECG changes with chest pain. And so then you start looking at all the other clues in order to narrow down the list. And that's how you come to some of these conclusions. So that way you can treat it appropriately and treat it effectively. And so that's kind of my way of doing that. And it served me quite well.
I'm gonna be honest. A big cheesy thing that I do is, so like I said, like go in with the funnel, but also I think a big part of that is like you talked about. There's a red substance of vomit in the bowl. I get really nosy sometimes, and I'll just look and be like, "What is that? Like what'd you eat today?"
Like dip your finger in it and taste it and see. Like,
it's the five senses, right? Smell it.
Those are
taste
beets.
it.
Those are definitely beets from Thanksgiving.
Oh, happy Thanksgiving. But just kind of using a broader sense than just like, I'm not putting down National Register checklists, but also like branching out besides just obviously you want to take care of your ABCs first before you do anything, your ABCs. But after that, I kind of jump around based on priority of like, okay, I don't really need to know right now what medications they take outside of a blood thinner, but I need to ask like the history and, like the OPQRST, stuff like that. So like I said, a big part of going in is understanding, even like you read your dispatch notes and you get there and they are two different things. So a big part of it is also like being able to quickly adapt to whatever's next. Or you have one patient that has, dude, like we had one, it was epigastric pain. It had been going on for about 2 days. She'd been throwing up, all this kind of stuff. So we did our 12 lead, did all the things. Nothing's really standing out. I was on the way to the ER, like a kind of standalone-ish ER. Could have handled everything that's going on, transfer her out if needed. We're about 6 minutes from the ER. And I just do like I normally do. If anything could be cardiac related, I run another 12 lead because it's not going to hurt anything. It takes like 7 seconds, if even that. I run it and I look at it. I went, huh? So I ran another one and I was like, oh. And so while I'm going up to the front to talk to my partner who's driving, I run another one and I go up there and I'm like, hey, there's going to be a change of plans. And she already knows, and she knows how our calls go. She was like, what's happening? I was like, bad things. We need to go to the other hospital, like right now. So I go and I tell the patient, like, hey, I think really bad things are happening. It's no need to be worried. And like, we're going to treat it right now. But, oh no. So it's a big part of what I believe in your differentials and understanding what's going on, using your clinical judgment. Is also like being prepared for what could go on, because even though your patient could have X going on, our patients don't fall into what I think a lot of paramedic school scenarios do of like, your patient has this, they are diaphoretic and clammy, and now they have chest pain. And now that our patients don't have the National Registry checklist in front of them, they don't know to call 911 and say, oh, my chest hurts, whatever it is. Like they have like a thousand things going on. So it's also like finding out what is your biggest top concerning differential priority that you have right now, and / or could it also be XYZ, like your patient that has a seizure. Like, okay, you do all your tests, you do all your figuring outs and all that stuff. Okay, it's a seizure. So what do we do next if they stop breathing? Then we go on to, oh no, let's fix their ABCs. Now the differential is they're unconscious, and we need to follow that. So that's just me, kind of like that tunnel vision of you lock in what you think is going on, and then you form like, okay, what's our next differential if this thing starts happening? Because my differential for that patient was, it's, I don't know, stomach bug, or it's, that kind of idea, which quickly changed to, oh no, which it was the, oh no, she was having a huge STEMI. And I called the ER like that we were on the way to. I'd already called report, and I'm like, hey, funky things are happening with the 12 lead. They're like, please don't bring her here. I was like, no, I'm not. We're turning around. So, but that's just me. I think it's also very important to have like a plan B just in cases. Or, it's what they teach you in paramedic school and what you learn in the field very quickly, have your differential, act on it, and be ready for the next step. Be ready for 7 steps ahead of where you're at right now, because patients have a funny tendency of deciding to do the very opposite of what is intended.
Those
So
jerks. Hey, jeez. Can you just be normal, please? I want to hear some of your radio reports. Like, I want to hear what they hear on the other end. Be like, hey, something funky is going on here. I want a nurse to be like, you know what, this has got to be Alexis. I know what she's saying. Cool. Yeah, go to the other hospital. Or it's just like, what does funky mean? Like,
dude, it's gotten to a point with the way some of these shifts go where called on a report one time and I forgot to include the unit number because my patient, I was like, they were like, hey, so what do you have? And I'm like, I have a 89-year-old female. And I just almost like, I don't know if it's sepsis or I don't know if she's having an MI. There are very bad things happening. I don't know what to tell you. I know her vital signs right now, and I'm doing a whole bunch of things. They're like, is this unit? And then she said our unit number. I said, yes. And she was like, she gave out a long sigh. She's like, how far out are you? I was like, we're 7 minutes out.
thank you,
So
but also don't judge
she
me.
lived. Yeah, the patient lived. She made it up to the ICU, stayed for a week, and then went home. And when I asked the ER like the next shift, and they were like, yeah, it was just bad. It was a lot. I was like, I told you. I tried to warn you. I'm sorry.
Oh man, that's funny. But I think I liked your story about changing in the middle of it too, when you're convinced it's one thing, a gastroenteritis kind of idea, and then you do a 12 lead, and all of a sudden you're just like, you have to completely change your perspective of that patient. That's actually really not easy to do. Luckily you had a diagnostic that was pretty cut and dry of having to change your perspective of what this patient was. I always kind of think of it like like when you do a blood pressure and it's like 130 on 80 and everything's good, and then you do the next one and it's like 60 on 40, and be like, there's no way that it's 60 on 40, it was just 130 on the 80, no problem. And then you run like 3 or 4 more because you're not convinced that they're hypotensive, and you just can't change your mind with that fact. That's something that does happen. I've done it. And
Right.
and I think that that's an important lesson to take from here, is that, like, patients are not linear in any way or shape or form. I wish they were. It would make our job a lot easier, but they're not. And so when you are convinced of differential, which is a great lesson, is that it doesn't mean that that differential is going to stay what you think it is all the way to the hospital. When things change, you need to pivot. And that's exactly what you did. And that's exactly what other paramedics need to do when they see something change in your patient, is to not ignore it, but investigate it and see if something's progressing, see if you are wrong about your differential and maybe there's something else going on, because now you're presented with a different clue. And that different clue can shift who the suspect actually is. Very much like a murder scene kind of idea. That's kind of how differential works, is that you're trying to figure out who the most likely suspect of the murder is. And as clues present themselves, it shifts your perspective of who that suspect is. So that's a really good a good lesson for new paramedics, is that don't get set on one thing and be convinced of that for the rest of the call. Things change, and you need to be able to adapt to that.
I'm not going to go on a soapbox of that's why we sit at the bench seat and not the captain's chair while we're doing a patient report or like we're doing a patient transport, because um, I know patients who they get picked up and it's possibly what was the one we had? Started off as a STEMI, about 5 minutes from the hospital turns into a stroke, or had one that we were like, oh, they're just intoxicated. They possibly had a seizure. 10 minutes later, I look up and I'm like, I looked at the guy that was my FTO at the point, and I was like, hey, I think he's having a stroke. Bad things are happening. So, I think that's, like I said, it's so important to narrow down your differential, getting your good patient history. what happened, looking at your patient, touching your patient, not inappropriate, obviously, but actually putting hands on the patient because you don't know if they're actually diaphoretic and clammy until what you know, you touch them. You wouldn't know if they're saying they're having an allergic reaction until I mean, they call you. You're allowed to look at their stomach with their consent. You're allowed to look. If you want to listen to breath sounds, wouldn't it be a gosh golly darn mistake if you just, while you're listening, you also looked at their chest rise and fall? That's just me. Anyways, hmm.
I think that could be a
So
whole other episode about doing primary assessments and what that actually entails and what it should entail. Because I think that the degree of which we complete them is so on two different sides of the spectrum, where we have paramedics that do a detailed primary assessment with every single patient, and then we have the ones that just do a focus assessment on what the original complaint was, and it's very um it's very detailed into one location, and they kind of ignore the rest of it. And so that really could be its own episode itself, is how important primary assessments are, and full primary assessments, in order to get all the clues that you can in order to figure out what's going on with your patient. Because I think that as a whole, EMS isn't fantastic at doing good detailed primary assessments, and we could do much better.
because you don't want to fall into that hole of they look like they're at 18 respirations per minute, and then you put an end title on. It's like, oh wait, it's 27.
Yeah.
Oh no. So
they look like 18. Like let's be honest. They all look like they're 18 breath.
I'm gonna raise my hand. I fall into that category sometimes, but just calling myself out. But yeah, that's all I got. 20 out of 10 recommend going to the Master Medics Instagram page, Facebook page, watching those videos. I'm gonna be honest, sometimes I watch videos and I'm like, oh, I know what's going on. Then I read through the comments and I'm like, oh yeah, that makes a lot more sense. Oops. So it's definitely obviously education centered, but it outside of work or even at work, I'll show my partner and be like, hey, what if we had this patient? That kind of stuff. So go find the video. It's a good one. Got me so good.
Yeah. We have that one pinned to the top of the page because it, like, everyone was losing their minds over that one. And sometimes I get trapped in this thought because I create the scenarios. And so it's easy for me to go, oh, this is that. But I already know the answer. And so sometimes I underestimate the comments sometimes and the discussions that happen, because I'm like, oh, I never really thought about that perspective because I already know the answer. So it's kind of interesting to see where someone's mindset will go and perspective will go from someone that doesn't know the answer. And so I highly recommend checking out the comments. But after you check out the comments, I also highly recommend seeking out the answer which we post, because you can go down quite a rabbit hole with the comments and end up at the wrong conclusion. And so it's great for learning and great to kind of understand how other people's mindsets work, but make sure that you figure out the actual conclusion. And we always do that as well to make sure that you're not lost. So yeah, it's been fun to create these. We shoot them every year. And that one, honestly, the red vomit was Gatorade. We did that. It was just Gatorade mixed with like oatmeal. And I didn't even think about the fact that it was red. Like when I posted that video, the fact that it was red was like a non-issue with me, which is ironic. It's kind of funny how those things happen. That's what I mean by you don't really realize the perspective of certain things, right? And what kind of discussions are going to come out of it. Because that was 100% by accident. If I'm being totally honest, that was an MI with bradycardia and a 3rd-degree block that needed to be paced. And it just so happened that they drank Gatorade 5 minutes prior to that. So we just happened to drink or spill some Gatorade in that vomit. But yeah, so it's just kind of funny how those things work.
Definitely check out those videos. And always, one of the things I search for, I read through the comments to find there's always one person that's like, isn't this a HIPAA violation? How can you get the patient's consent to record? It's like, you you obviously, or the ones that, oh my God, you posted them one of, it was a pediatric resuscitation after drowning.
Mhm.
And somebody was like, they said something so out of left field that it like, I literally read it and I'm like, it's a mannequin. Are you anyways, those are my favorite ones. Those
Yeah.
are the ones that I'm like, okay, okay, guys, do you not understand? Anyways.
I take it as a compliment because if people are like, "This is a HIPAA violation," or "You shouldn't be showing, children in cardiac arrest," and I was like, if
Yeah.
those are the comments that we're getting, it means that we're creating stage scenarios that are realistic enough to get people uppity. so, so I'm taking it as a compliment that we're doing something right, where they can't tell the difference between a real call and the stage scenarios that we're doing, and all of them are staged. Not one of them has been a real call or a HIPAA violation. None of them have, because they are all stage scenarios that that we've created, that we've produced and shot ourselves with real paramedics and real actors, and it's come out really well, and it's created a learning environment that that we're really proud of. And but yes, the answer to your question about HIPAA, we did not violate any HIPAA unless the mannequins have rights, which I don't think they do.
Father HIPAA, you can stay at rest. But oh, so yeah, man, that's all I got. I mean, if you want, we can go on another episode later on about assessments, and I can pour my heart out into that. It's definitely something near and dear to my heart. But Geoff, if that's all you got, that's all I got. And as we end every single episode, but this one especially, we're going to give a happy Thanksgiving. I don't know when this was actually going to air, but as the American way of Thanksgiving in November, happy Thanksgiving. And as we end every episode, so with that.
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.